Well, thank you. I hope you don't have the postprandial snoozes, so we're going to wake up with a little excitement and move right ahead. So this panel is about hemorrhage, as Dr. Carvalho said, and my focus on this segment is mostly about the CMQCC guidelines. All right, that's Cedar, Sinai with our new building, and this is the view from labor and delivery at either dawn or, dawn. Anyway, disclosures, no disclosures. I am passionate about maternal and baby well-being. What are we here to learn today? To recognize hemorrhage, understand the assessments, implement current therapies and protocols, and understand the role of communication. So you're fortunate to be here today because of all the topics you're going to hear about at this conference. Obstetric hemorrhage is the one place that it's easiest to make a difference that matters, and you can save lives by doing this. So thank you for being here. So CMQCC, California Maternal Quality Care Collaborative, they were the first organization really to issue hemorrhage guidelines. They were implemented within California. They were revised a little bit, so that's what I call version 2, and that's what we're going to talk about today. So sort of what's the new changes? Active management of the third stage of labor. So we're going to give oxytocin. No need to wait for cord clamping. Delayed cord clamping, as many of you know, has become sort of more popular. There are some benefits to the baby. If there's nothing else you remember from this lecture, it's give more FFP, or more scientifically, after the first 2 units of packed cells to give a 1-to-1 ratio. Although there is some debate. Some people are still arguing, well, you could give 1-to-2, but for now, let's just say stick to 1-to-1. And we're going to optimize some of the smaller characteristics like ionized calcium, acidosis, and hypothermia, all of which affect the clotting cascade. And factor 7 has been downgraded in terms of its usefulness from the perspective of the CMQCC guidelines. And they've added support the family needs. I might extend that a little bit and say family and staff needs. Certainly after maternal morbidity or mortality, the staff need a lot of support also. So obstetric hemorrhage. I just want you to take the big picture view. There are a lot of slides. It's in the handout that you can download. I like to have the slides, all the details with the references, so it's there if you want to look at it. But we have 2 other speakers, some of whom are going to talk about some of the same issues, so I may skip over some slides quickly. No disrespect intended, but other people are going to talk about it, but it's still there in the handout if you wish to go back to it. So OB hemorrhage, the traditional definition, what is hemorrhage? Is more than 500 milliliters of blood loss after vaginal delivery, or a liter with a cesarean. Hemorrhage can occur in up to 3% of all deliveries and can be perceived as life-threatening in 1% to 2%. The incidence of postpartum hemorrhage increased 30% over a little over a decade, and blood transfusion doubled to almost 1 in 200 moms. What are the major causes? We're familiar with these, right? Uterine atony is over half. Retained placenta. I find that the vaginal laceration or some cervical tear to be some of the harder for them to detect and see. You're familiar with those. Hemorrhage, morbidity increase. So for every maternal mortality, it's been estimated that there are 50 to 100 times the morbidity or near misses. So morbidity increased by 75%. Over 50,000 women a year face morbidity from OB hemorrhage. Transfusion, like we said, is near 1 to 200. And even that people get readmitted, which is certainly morbidity at a higher rate than originally expected. Maternal mortality is number one cause worldwide, as Dr. Carvalho mentioned. Accounts for 15% of the maternal deaths within the U.S., although that has improved, but it's about 1 in 50,000 births. The reason why we're all here is to learn what we can do to help prevent some of them, because the majority of them have been deemed, in theory, preventable. Here we see data from the California mortality. This was a reason why the California legislature and Department of Health funded the CMQCC. Mortality was rising. Some of that might be due to the incidence or changing over to ICD-10 coding. But CMQCC came out, they published the guidelines, and maternal mortality started to drop. So, as they say, this stuff works. Here we can see that racial disparities exist even in maternal mortality, being 2 to 3 times as high as for non-African Americans. So this was, again, it's the same type of data from multiple sources. Bob D'Angelo, I saw, he's in the audience. He led the study from the SOAP Series Complication Registry. And again, 1 out of 3 of the maternal mortalities were hemorrhage related. So I said, these 3 series of lectures, you can learn fancier stuff, but this is where the rubber meets the road. So what are the causes? Well, we're all taught this kind of a list. Uterine atony, retained placenta, some placental abnormality, whether it's previa, abruption, accreta, surgical, certainly tear, or developing coagulopathy. Right, uterine atony, any kind of prolonged exposure to oxytocin. 24 hours is the rule of thumb, although it's not. An on-off switch is a continuum. Whether it's endogenous, spontaneous labor. Sometimes we get people coming from what's deemed failed home births. They've been home for quite a while before coming in, or induction of labor that goes slowly. And I suspect that oxytocin receptor downregulation occurs probably faster than we have previously thought. Certainly infection, uterine physical abnormalities, either fibroids, bifid uterus, anything that'll overstretch the muscle, whether it's twins or polyhydramnios, medications that may relax the muscle, such as magnesium, which in and of itself is a calcium channel blocker, nifedipine, as well as what we all learned in residency, the potent inhaled anesthetics. Right? You could get coagulopathy or DIC from other sources, including HELP syndrome or amniotic fluid embolism. The studies that look at where our maternal morbidities and mortalities, sepsis has been on the rise. So recognition, right? We've talked about the definition. We have going to institute hemorrhage protocols. I remember from when I was taught, the pulse and blood pressure will change when volume status changes. However, it's probably not quite as reliable as we thought. You want to have your equipment ready, including some form of rapid transfuser, an intrauterine balloon to help stop the bleeding. Usually they use a Bakri balloon, and have your support services from the blood bank and interventional radiology, and perform drills, which you'll hear about later. So they've made it easier by dividing it up into stage 1, 2, and 3. So stage 1 is more blood loss, and it can be a little confusing. Stage 2 is less than 1,500 ml, and 3 is greater than 1,500 ml blood loss. So certainly that's significant, in spite of the fact that in pregnancy we are starting out with an increased maternal blood volume. So there's a large degree of inaccuracy in the estimated blood loss. So EBL is out, and QBL, or quantitative blood loss, is in. You want to find a way to accurately measure. You can use graduated markings for the drape under the buttocks for a vaginal delivery. For surgery, or even in a vaginal delivery, you can weigh all the laps and sponges. And multiple studies have shown that even, you can do better when you get visual training, but the tendency is to underestimate large losses by up to 50%. So that's very significant, right? That's being off by a factor of 2, and that small blood losses are overestimated, although clinically that's not going to cause as much of a problem. You may use certain technology aids. At my institution, we actually use one of the devices out in the vendor area, the Triton. So one thing that I like about it is it'll take a picture of the canister, the suction canister in a C-section, and it'll tell you how much blood there is. So it accounts for the amount of amniotic fluid, which can be, obfuscatory in terms of how much the EBL is, or if they do a lot of irrigation. So these are the drapes. You can put a graduated drape and measure. The picture makes it a lot easier than in reality, because usually the OB's throwing the trash and the sponges and the other stuff in there, so it's not quite as obvious. Ooh. Okay. Nope. All right. National Health Service in the United Kingdom was the first to come out with the maternal obstetric early warning system, which I know Jill Meyer has adapted to just Muse, maternal early warning system. That was the slide we didn't see about training for the visual blood loss. So you can train people, the staff, the nurses, the doctors too can go through this, and it'll improve the accuracy of the estimates, but the estimates are still not good enough. Here's the early warning system, just a visual way that, the basic parameters, blood pressure, pulse, respiration are abnormal, and therefore you should take action. This is in another format that might be easier, and they were based on if something's basically abnormal, then call a physician, the obstetrician, to come and assess the patient. We were all taught, or at least I was taught way back when, pulse and heart rate will change as your volume status changes. Over the years, I've come to appreciate that in young, healthy women, they can tolerate a substantial blood loss before I really see an increase in the heart rate sometimes. Here's a study from a trauma journal, but the sensitivity and specificity is certainly a lot less than 100%. So what are the current treatment protocols? Dr. Scavone is going to get into this part, so I'm going to skip through these, but you want to have your stuff ready, have thought about it, have an assessment. Hopefully the assessment and some kind of communication occurs when the patient comes in. Certainly be doing quantitative blood loss, active management of third stage of labor, have protocols in place, and psychological support. That's a newer thing for families, and I think also for the staff. And reporting systems, which again, Dr. Scavone is going to cover in a few minutes. So what's new and old? It's active management of the third stage of labor. So oxytocin, right, we used to give it after the baby was out. Now we do it when the shoulder is delivering, if it's vaginal, or as soon as the baby's out of the uterus during a cesarean section. So they say, it's new, but that kind of gives me a chuckle, because I remember when, if you go way, way back, baby would come out, women would get IM injection of oxytocin or methergin, and then that would force the uterus to contract and spontaneously deliver the uterus. And then in a couple of percent, the uterus would get stuck, which is why they said to wait, and now we're going back. So this isn't the first thing which has been gone 180, only to go another 180 back to what they used to do 50 years ago. So the main tool that's been validated and encouraged from multiple sources is continue the vigorous fundal massage is one of the best ways to maintain firmness. These tools have decreased postpartum hemorrhage rate, at least in the immediate postpartum period, by up to 60%. And again, it's okay to use with the delayed cord clamping. Also, sort of a change in thinking, rather than used to be, again, old style was give a lot of crystalloid and colloid and try not to give blood products. In OB hemorrhage, you want to keep the crystalloid to a minimum. Rule of thumb is 2 liters or less, and if you're bleeding that much, to start the blood product early. I have a couple slides to show you the data, but giving FFP more than we used to, and in that 1-to-1 ratio, reduces mortality. This is from a trauma journal, but the people who got more FFP had a better survival. Here's another study, PROMIT, major trauma, more FFP, better survival. The proper trial, severe trauma, so the 30-day mortality was not significantly different, but the blood loss was less within the first 24 hours. So what stage 1 bleeding, we said, is more than 500 for vaginal delivery or a liter in the cesarean section. Vital signs change of 15%, right heart rate above 110, blood pressure below 85. So what do? You break it down to the simple things, call for help. That's number 1, communicate, activate hemorrhage protocol. You know, you might start a second IV, cross-match, give uterotonics, think about what's going on. Stage 2 bleeding, you're continuing to bleed, you're having some instability in any of your vital signs. You're going to give additional uterotonics, you know, start transfusion. You do not need to wait for labs. You can transfuse. The threshold for transfusion in maternal hemorrhage is different than in the main OR for a regular case. You can lose blood fast, and if you don't catch up to it, you can go downhill quickly. And the whole issue of what do I do in maternal hemorrhage, basically give more blood earlier than you would in other circumstances with FFP, and you can help the whole cycle. So rapid transfusion equipment is particularly helpful. And think about opening them up. Once you get to stage 3 bleeding, which is more than 1,500 blood loss, or you've already given a couple units and you're having trouble with the vital signs, you know, or DIC, you're going to need to stabilize, and they'll probably need an ICU or some step-up unit. You want to move to the OR if you're not already there. You'll need surgical consultation. Certainly in smaller hospitals, you may not have the next level of surgical assistance readily available, but most of the OBs will call in their GYN oncology colleagues for massive hemorrhage to help with, oh, do I need to do a hysterectomy, or physically help with that. Massive transfusion protocol should be present and activated from the blood bank. All I do is make one phone call, massive transfusion protocol. I get 6 PRBCs, 4 FFP, and a bag of platelets without hassle or delay. You know, additional lines. Sometimes, right, when do you need to move to the OR and open up or take a look? That can be a sticking point. So again, communication from you to the OB, and I've been told, as I'm sure many of you, multiple times, oh, the uterus is firm, or you don't see blood coming out of the vagina. There are other places you can be bleeding. So if there's any issue, do communicate with your OB, and if you need to, you can escalate along the chain of command. So we said transfusion, don't wait for labs, whole blood or equivalent. You know, you can start with the 6 to 4 to 1 for packed red blood cells, FFP, and platelets, and then just go 1 to 1 on the FFP and blood. If fibrinogen is low, you might need some cryoprecipitate. Recombinant factor 7 has been talked about a lot. In the first version with CMQCC, it was listed as a possible thing after everything else doesn't work, and it's still there, but they kind of discourage it. There have been a lot of reported cases of complications from thromboembolism. Again, don't expect you to read the slide, but if you go to cmqcc.org, you can download all their hemorrhage toolkit, as well as their other toolkits, which are excellent, including preeclampsia. It's not a conflict of interest, but I was on the preeclampsia task force, you know, and download those for free and look at them more thoroughly. So repeat labs every 30 minutes, check for the ionized calcium, normothermia, keep the fibrinogen levels up, transfuse 1 to 1 FFP certainly after the second PRBC, and just automatically give platelets. Even if you think, well, they haven't bled that much, I don't know if I need it, it's just sort of part of the package. Here's a comparative chart. Some of this is my personal data. Some of it's from outside my experience, but from organizations. So what gauge IV and how fast can you transfuse? So using sort of the standard, level 1 rapid transfuser. I've timed it many times with just the standard OB patient with an 18 gauge IV who's bleeding. And I bring it in and hook it up. It takes about 5 to 6 minutes for 1 unit of pack cells. Doing that, the Belmont rapid transfuser, that's the kind where you put all the units into the big bucket and then just turn the dial. Through a 14 gauge central line, you can give up to 500 ml. So if you're doing an accreta kind of case, that's become my new first go-to, and it helps a lot. It has reduced the stress on my coronaries significantly. Risk factors, again, prolonged second stage. This study is from Stanford down there. Thank you, Dr. Carvalho. So prolonged second stage increases your chance for atony by a factor of 2, right? Women who bled had higher maximum oxytocin infusion, longer duration. Magnesium, which we said works by being a calcium channel blocker, or an episiotomy. And again, like I said, my personal sense is the oxytocin receptor downregulates faster than we're traditionally taught. So what wasn't on that list from Stanford? Well, epidural. We get blamed for a lot of stuff, but not this. You can see here one of my residents who became a fellow did this creation, but you can see she's delivering with an epidural, having no problem pushing and no bleeding. And credit to that goes to Dr. Jimenez. So uterotonics, right? Normally CMQCC says 10 units is enough. Ongoing debate. No real need to get into it. For this session is how much oxytocin is enough. Do you need 3, 5, 10 units? I'll let other people talk about that at a different time. But so oxytocin, move on to methylargonavine. 0.2 milligrams IM is the traditional thing. Some people are talking now about giving it orally. The bioavailability orally is 60% compared to almost 80% if you give it IM. PGF2 alpha, also called carboprost. And I'm trying not to use the trade names because we're not supposed to. You can give it IM or directly into the uterus, right? You can give it every 15 minutes up to a maximum of 8 doses, or misoprostol. So the dosing on the misoprostol used to be 1,000 micrograms rectal, and that recommendation has changed recently to just give it sublingual. 800 microgram dose is enough. There's a few papers I've read where they're in countries with less resources, where they don't have IVs and they're getting OB hemorrhage. They just do 200 sublingual, and that takes care of most of their OB hemorrhage. Although you may have OBs, as I do, who wind up doing all 3 of those drugs, methylargonavine, carboprost, and misoprostol. Misoprostol actually gets metabolized to essentially the carboprost, so there's pharmacologically there's really no need to do both. Women who do both, who get both, I can tell you from experience, they get the shakes, they get massive diarrhea later, and the nurses hate it. Okay, communication, keys to success in closed claim studies, right? Need to communicate with the blood bank urgency. If you've set up massive transfusion protocols, like I said, that shouldn't be an issue. Help getting the equipment, rapid transfusers, the intrauterine Bakri balloon. Here's a study I found recently. Delay equals arrest. If you can see over here, this is a study from Japan, but obstetric hemorrhage delays from 1 to 6 hours. If you delay taking them back to the OR and treating them, you increase your chance for maternal arrest. Closed claims OB. OB hemorrhage is disproportionate in the closed claims database compared to non-OB cases, significantly with a higher mortality rate and greater payout, and the main issue there was delay in transfusion. So again, the trigger point for starting transfusion in OB is going to be a lot lower in terms of starting it. And, you know, even if philosophically you want to say we're tending to over-transfuse, it's considered to be a little bit safer than like in the main OR where we're, oh, don't transfuse unless you really need it. Preventability and communications, closed claims, there were communication lapses. This lower one is a study from New Zealand. So a little bit lower in terms of the preventability, but, you know, same theme, communication, take action. So pre-delivery huddle, it's nice for high-risk patients or all patients who are at increased risk when they get admitted to alert the other team members. You want to use quantitative blood loss. That takes a lot of the conflict out of it. That's one thing I really have liked about switching to a QBL format and measuring is a couple weeks ago I had someone with twins with poly, and there was so much in the bucket, and rather than get into it about, oh, is that 500 a liter, 2 liters, because you filled up almost 2 canisters, you know, you had we measured it, and then, okay, number wasn't too bad. You know, it was only 600 something, and so it could just depersonalize. Oh, I don't lose that much. Yes, you do, and all that. I'm sure you've been there. So, you know, that's the denial part, or a lot of times, like in the PACU, someone has a section, you go to PACU, they start to bleed, and you say, oh, they're hypotensive, we need to take them back. No, it's firm, I don't see any blood coming. You know, if you're hemodynamically unstable, that's the key point. You should go back, and you can, again, activate your chain of command if you need to. So recognize denial and delays. This was from the SOAP CPR article where, you know, communicate, read back, do team drills we're going to get into in just a moment. I have a couple of, I like factoids, I don't know, so I'm sharing them with you. So ACRETA, CMQCC and ACOG have really recommended formation for ACRETA teams and referrals, right? I hope you're all familiar with the ACOG, SMIFM, maternal levels of care, hospital designation, similar to the NICU. So you want to send the ACRETAs. And at Cedars, we are in a ACRETA referral center, and we've got a whole network, so I wind up seeing and doing a lot of these cases, and it has really helped the efficiency and the flow and the patient outcomes when they're transferred and we're sort of set up. Ultrasound is very sensitive. MRI is slightly more sensitive. Which test you get, of course, is up to your individual center. We are also a referral center for Jehovah's Witnesses. So the published statistic, maternal mortality from hemorrhage, for Jehovah's Witnesses, as stated, that's 1 in 2,000, looks like. But, you know, it's good to meet with them. You go over the list, some medications that you might use, you know, have traces of albumin or derived, so it's good to go over the exact list. CMQCC has a toolkit, including the Jehovah's Witness one. We've adapted that for our own use at my hospital, but, you know, you can use Cell Saver. Almost everyone will accept that. If their hemoglobin's low, sometimes IV iron is given. See what you could do pre-op. As I said in the beginning, this stuff works. Larry Shields, along with Elliot Main, led CMQCC, and he instituted all the protocols early within the Dignity Health system. And we'll just say that it reduced blood utilization. Those are the goals which we talked about. But due to increased scrutiny and identification, stage 2 hemorrhage increased, stage 3 hemorrhage increased. So that was more probably of an identification, training and identification scheme, and they used way more FFP, but in the end it wound up decreasing usage of packed cells, platelets, and cryo, which means you gave enough FFP to help stop it before it got worse, and that's the key. Recombinant factor 7, we said it's still on the template. The dose is there, but it's there, but discouraged it as the sort of read between the lines. And TXA, we're going to hear about from Dr. Sullivan in a few minutes, so it can be useful. It's been shown in trauma to help. We are using it more and more in my practice. And this is the slide sometimes it's hard to find the key data you want. So here it is. This one talks about the severe morbidity, and you see that the rate is 50 to 100 times that for the mortality, and that's where we have reasons and opportunity for improvement. But like most things, once you measure it, then you can benchmark and see where you're going. So again, the takeaways, life-threatening hemorrhage occurs fairly commonly. We want to avoid delays in diagnosis, underestimating the blood loss and shifting from EBL to QBL. Be more aggressive. Make sure you check for those lacerations high up on the vaginal sidewall or cervix. There's sort of a push to let the family member be in the room, that for codes and for situations like this, that if the family member sees all the activity you're doing, that they will generally feel better about the care given. I wonder about the possibility of PTSD for the family member or the staff. It's a little harder when someone else is in there and sometimes interrupting you. And there have been suggestions for using the pneumatic anti-shock garment to help during a hemorrhage. But since they're usually in the vaginal area and palpating the abdomen, it's not as easy as it sounds. So we've learned today to recognize OB hemorrhage, understand the assessments, right? The meows, the quantitative blood loss, the staging of the blood loss, and the actions you should take from them, and communication, as well as a couple bonus slides I've thrown in. And if you've learned all that, you can go to your happy place. This is one of my happy places, my friend's home outside of Durango, Colorado. Thank you very much.